So good morning, good afternoon, and evening to all participants in this first webinar of the Coalition of Centers in Global Child Health, focusing on the extremely important issue of this multi-system inflammatory syndrome that everyone's, particularly those in pediatric care, are quite concerned about. Epidemiologists are trying to get their head around this. So I'm Bhutta. I am the chair of the Coalition of Centers in Global Child Health and a chair in Global Child Health and Policy here at the Hospital for Sick Children in Toronto. And I'd like to take a second to introduce the coalition to you and then introduce our speakers briefly by name only, and then pass the floor to Adnan Bhutta, who will be moderating this session by and large. So the Coalition of Centers in Global Child Health started as a voluntary coalition of institutes and departments, centers engaged in issues of global child health some 7 years ago now. And the coalition basically was put in place because we were concerned that in the wake of the sunsetting of the Millennium Development Goals and the focus on the Sustainable Development Goals shifting to a much broader arena, that there may be issues where we needed, as a fraternity of child health specialists and pediatricians, particularly those involved in global health work and research, would need to join hands to focus on areas that were hitherto ignored. So basically, it's an advocacy, capacity development, collaboration, and research-focused coalition of now close to around 47 centers across the world, of which the large majority are in the proverbial South. So we have centers which are from Africa, from Asia, Southeast Asia, and a reasonably large number in Europe and North America. So we're very proud that we've been able to keep this coalition going. And I hope that following the current global crisis that faces children and adolescents worldwide, that support for joining hands and becoming part of this coalition will grow. And if you need to find more about it, just Google the Coalition of Centers in Global Child Health, and our staff will be able to send you information. So today I'm very pleased to introduce this webinar, which is focused, as I mentioned, on the important issue of multisystem inflammatory syndrome. And this is a major public health issue, not just from the point of view of health, but also of its implications in relation to education, opening of schools, and the entire issue of how children relate to broader dissemination and broader epidemiology of this disorder. We have a fantastic panel. We have 4 speakers. Professor Adnan Bhutta from University of Maryland School of Medicine in Baltimore, Dr. Shaun from the Hospital for Sick Children here in Toronto, Dr. Pablo Rojo, who is a pediatric infectious disease specialist in Madrid, in Spain, at the University Hospital, and then Dr. Jhuma Sankar, who is an associate professor in the Department of Pediatric Epidemiology and Critical Care Medicine at the All India Institute of Medical Sciences in India. So I'd like to very warmly welcome them all. They will be introduced by Dr. Adnan Bhutta, and I will introduce him and then pass the floor to him to moderate this session. So Adnan is, as I mentioned, a professor in pediatrics and division head of pediatric critical care medicine at the University of Maryland School of Medicine in Baltimore. He also serves as the co-chair of the Global Child Health projects related to pediatric clinical care and intensive care. He has spearheaded a large network of pediatric critical care units in North America and has been involved in several clinical trials, notably in Malawi, in Africa, in the areas of improving outcomes related to mechanical ventilation and treatment of children with cerebral malaria with intravenous fluids. He started the first ever fellowship in global health for pediatric intensivists, and he's leading, importantly, the pediatric response to COVID-19 at the University of Maryland Medical System. And I know, Adnan, that you have spoken extensively about this issue, and I'd like to pass the floor to you to introduce Shaun and to principally moderate this session. And I'll be available for providing any inputs in due course. Thank you.
Thank you, Professor Bhutta. It's a great pleasure to moderate this session. The order of speakers that the way that we will do this is we'll start with Dr. Shaun Morris, who will be followed by myself, and then Dr. Pablo Rojo, and at the end, the last speaker will be Dr. Jhuma Sankar. So Dr. Morris is a clinician-scientist in the Division of Infectious Diseases and a scientist in Child Health Evaluation Sciences and the Center for Global Child Health at the Peter Gilgan Center for Research and Learning at the Hospital for Sick Children, or SickKids, in Toronto. He's an associate professor of pediatrics with an appointment in clinical public health at the University of Toronto. His major global and domestic research focuses on reducing childhood mortality and morbidity from infectious diseases and neonatal sepsis. He is the co-PI of the Canadian Pediatric Surveillance Program, COVID-19 study. It gives me great pleasure to introduce Dr. Shaun Morris, who will be talking about the epidemiology and presentation of COVID-19 in children. Shaun?
Thank you, Adnan, and thank you, Zolfi. Let me try to share my screen. Can someone let me know if they can see my screen right now?
Yeah. Yes.
Great. Okay, so thank you very much for the introduction. I'll speak for about 10 minutes before passing it on to Adnan. So to start with a couple important points about terminology. So SARS-CoV-2, or Severe Acute Respiratory Syndrome Coronavirus 2, is the name of the virus that we'll be speaking about today. And COVID-19, which stands for Coronavirus Disease 2019, is the name of the actual disease in humans caused by the SARS-CoV-2 virus. So what are coronaviruses? Coronaviruses are a large family of RNA viruses that infect humans and, very importantly, animals. In fact, the vast majority of these viruses are in animals. There are hundreds of different coronaviruses, most of which circulate amongst animals such as pigs, camels, bats, and cats. And bats are particularly important, and we'll touch on this in just a few minutes. Prior to the novel coronaviruses, there are in fact only 4 known coronaviruses that caused seasonal mild to moderate upper respiratory tract illness in humans, particularly in children. However, over the past 2 decades, 3 novel coronaviruses have emerged from animal reservoirs to cause serious and widespread illness and death around the world. So to briefly touch on the 3 novel coronaviruses, so SARS-CoV-1, we can now refer to it as, the SARS coronavirus first emerged in November 2002 in Guangdong province in South China, and subsequently spread globally, including to my hometown of Toronto, which was one of the cities outside of China that was most affected in the entire world, particularly amongst healthcare workers, of whom multiple unfortunately died. The Middle East Respiratory Syndrome, MERS, is caused by the MERS coronavirus, or MERS-CoV. So this virus is transmitted from an animal reservoir in camels to humans. It was first identified in September of 2012, and it continues to cause sporadic and localized outbreaks. And then finally, of course, the 3rd novel coronavirus to emerge over the last 20 years or so is the SARS-CoV-2 virus, which causes, as we said, COVID-19, and which originally emerged in China. It was first recognized in December of 2019, but I think there's increasing evidence that it actually probably emerged in humans some at least number of months before this, and rapidly spread throughout the world and was declared a global pandemic by the World Health Organization on March 11, 2020. Now I mentioned bats, so it's now thought that even if there are intermediary animals, such as the case with MERS and camels, it's thought that it's most likely that all 3 of these viruses had their origins in bats. So as a brief high-level comparison between the 3 novel coronaviruses, SARS, MERS, and COVID-19, in 2002-2003, SARS caused just over 8,000 cases around the world And of the known microbiologically confirmed cases, there was a case fatality rate of approximately 10%. Now, MERS, of the known cases, seems to have a much higher case fatality rate. So about a third of all of those who are infected have died. However, human-to-human transmission seems much more difficult with MERS, and there have only to date been about 2,500 cases in humans described in the world, the vast majority of these in Saudi Arabia and the Middle East. And of course, COVID-19 has shown itself to be very efficient at human-to-human transmission, both from symptomatic and pre-symptomatic and asymptomatic individuals to other people. As of the most recent counts yesterday, there's over 10 million confirmed cases around the world, and no doubt the actual number is much, much higher, perhaps an order of magnitude or more higher. The death rate amongst those with confirmed cases is about 4%. However, because the denominator, as I just mentioned, is probably quite a bit bigger than 10 million, the true death rate is thought to probably be closer to about 1%. Now, this obviously seems much lower than SARS or MERS. However, it's important to note that compared to a virus like seasonal influenza, which is estimated to have a case fatality rate of about 0.1%, the case fatality rate of COVID-19 is still very meaningful. So I'm going to show some very recent data from Canada, not because Canada is unique in terms of its COVID-19 epidemiology in general and in children, but more because it's representative, I think, of what has happened in essentially every at least higher income country that has had a local epidemic of COVID-19. So these numbers are from the Public Health Agency of Canada. They were published just 3 days ago. And what we've seen so far in Canada is that about 6 or 7% of all microbiologically confirmed SARS-CoV-2 infections are in children and adolescents under the age of 19. Now, it's important to note in Canada and essentially in every other country that how testing has been done affects these numbers. So as I'll mention in just a few minutes, because children are less severely affected, they are probably tested less often. And because they are not one of the groups that has been noted as a priority group, so in general, the elderly or people in long-term care facilities or other at-risk populations, they're simply tested less often. So I think it's fair to say that the true prevalence of COVID-19 in children still is a little bit unclear. Now, I think we all know that numbers related to hospitalizations and ICU admissions are probably somewhat more accurate and more likely to be properly counted. So I want to show these two figures on the right. The top bar graph is the rate per 100,000 population by age in Canada, and the bottom bar graph is the rate per 100,000 population for ICU admissions by age and gender from SARS-CoV-2. And in both of these cases, what you can see is that the under 19 age group is obviously a very, very small contributor to the morbidity from SARS-CoV-2 in the overall population. So moving now into some of the key clinical aspects of acute SARS-CoV-2 COVID-19 infection in children. So as I said, so the data from Canada and multiple other countries seems to show that somewhere between about 1 to 6 or 7% of all diagnosed cases are in children. Children typically have mild or even completely asymptomatic disease. However, it's important to note that severe disease and deaths have been reported. So the first large case series was by Dong et al. It came from Wuhan in China. It's about 2,100 children who were included in this case series. And what Dong et al. Found was that of those cases that were deemed severe or critically severe, 60% were in children under the age of 5. So this is the first important point, is that it does seem that there is an age-related risk factor for SARS-CoV-2 infection in children, whereby younger children are more at risk for severe disease. One of the first case series from the United States found something similar. So out of 147 children who were hospitalized, the highest proportion of children who are hospitalized were in those who are under 1 year of age. They also found that adolescents tended to behave more like adults in terms of the specific risk factors. So things like obesity, asthma, and diabetes, these chronic diseases, which have been well described in the older populations to be related to more severe disease. So when a child is symptomatic, most of the time they have what appears to be a relatively mild upper respiratory tract infection, so very similar to other respiratory tract viruses. However, there's a couple very important points on this slide. So the first is that only about half of children have a fever. So this is really important because fever is often used as a screening criteria and a warning sign that a child is sick. And only about half of children with COVID-19 seem to have a fever. The other really important point is that I think we're recognizing that SARS-CoV-2 is certainly far more than just a respiratory tract infection. It can involve multiple organ systems. And in children, an isolated gastrointestinal presentation with diarrhea and/or vomiting and complete absence of other symptoms is not rare. So in children, this can appear just like a gastroenteritis. The loss of the sense of smell and sense of taste that has been well described in adults also can happen in children. And certainly I've looked after a few children who had nothing but a loss of sense and loss of smell. And another feature that seems to happen in children more often than in other populations is this entity called COVID toes, which is this development of a rash sometime after generally the acute infection on the toes or the soles of the feet or sometimes the hands. And it's thought to probably be a vascular manifestation, an inflammatory vascular manifestation of SARS-CoV-2 infection. So I just want to wrap up with a very important study that was published just 5 days ago on June 25th in the Lancet Child and Adolescent Health Journal. So this is the first large case series that's come out of a country other than China. And so it's important for that reason. This is 82 centers across Europe who contributed cases that were diagnosed both in acute care hospitals, as outpatients, and in screening centers. In total, there were 582 individuals with microbiologically confirmed SARS-CoV-2 infection that were included. The median age was 5, with slightly more males than females. About a quarter had a pre-existing medical condition. Almost 2/3 required hospitalization, and 8% of the total cohort required ICU admission. Of those in ICU, you can see that a significant number required mechanical ventilation or inotropic support. I do want to note that the median duration of mechanical ventilation was 7 days, which does seem to be longer than would typically be seen in children with other respiratory viral infections such as RSV or influenza. And I think that this is similar to what we're seeing with adults. When adults are ventilated, they tend to stay on the vents for quite a long time. I just want to highlight a few things in my last slide from the features of the ICU cases compared to the non-ICU cases. So similar to the Chinese study, similar to the American study, the children who were admitted to the ICU were disproportionately under the age of 1 month, so they were newborns. Males seem to be slightly overrepresented in the ICU admitted children, again, consistent with what's been seen in adults. One of the big questions in pediatrics is if so, which underlying comorbidities increase the risk for severe disease. So this group found that underlying comorbidities were disproportionately represented in those children who required ICU admission. Okay, so some slides aren't showing up, but specifically pulmonary disease, congenital heart disease, malignancies, and neurologic disorders were the types of conditions that were most represented in the ICU population. And the final thing that I want to highlight is the very, I think it's actually being cut off of the slide, but it's that children who had concurrent infection with other viral respiratory infections were more likely to be admitted to the ICU. And I think that this is really important because one of the big questions in pediatric COVID is what will happen if there is a second wave at the same time as the viral respiratory season. So at least in the north, in the next few months, we'll be having increases in RSV, influenza, and other respiratory viruses. And I think it's actually very concerning that this paper is suggesting that children who are co-infected tend to be more sick. So thanks very much. It's a very quick overview of acute COVID in children, and now I'll pass over to Adnan.
Thank you, Shaun. I was just, Jessica, can you pull up my slides?
Yes, I will pull them up right now.
Thank you.
Can you see them?
Okay. So what I wanted to focus on for the next 15 minutes or so is the pathophysiology of the multisystem inflammatory syndrome in children, and just want to focus on the fact that what we see in MISC is a pathology that is akin to what is seen in adults, in that there is a hyperinflammatory and hypercoagulable disease process. Next slide. So I have no disclosures at this time, and the objectives of the talk are, again, to understand the inflammatory response associated with severe COVID-19 disease, and then also to understand the effects of COVID-19 on the coagulation system. So I was just driving in this morning, listening to NPR, and they mentioned that it has been exactly 6 months since the WHO first got reports from China about a new viral infection that was doing the rounds in Wuhan. And a lot has happened in those 6 months. Next slide. What we've seen, sometimes sitting despondently looking at this Johns Hopkins map, is the steady increase in both the number of cases as well as the number of fatalities around the world. So just yesterday, we crossed 2 marks, one of there being more than 10 million reported cases of COVID-19 from around the world, and also of more than 500,000 deaths from COVID-19. So it remains a present and growing danger. So SARS-CoV-2 is certainly a new foe. Next slide, is a new foe that we're seeing the likes of which we have probably not seen in more than a century since the influenza virus outbreak in the 1917, 1918 timeframe. So next slide. So one of the things that is important is to understand and how to fight any virus is or any enemy is to actually know the enemy. So Sun Tzu in The Art of War very succinctly puts it that if you know the enemy and know yourself, you need not fear the result of 100 battles. You know yourself, but not the enemy. For every victory gained, you will also suffer a defeat. If you know neither the enemy nor yourself, you will succumb in every battle. And I think when this outbreak first started, it looked like we were succumbing in every battle. But over the next few weeks and months, we have learned a lot. Next slide. We have learned that, next slide. We have learned the structure of the SARS-CoV virus, as Shaun alluded to. We know what receptor it acts on, which is the angiotensin 2 type 2 receptor. We know the modes of transmission, that is primarily airborne, but it can be essentially be through any body fluid. We also know the concentration of viruses in different areas of the body. We know that it can stay stable on surfaces for hours and sometimes days. And then we also know that it takes a few days to a couple of weeks to seroconvert and develop an antibody response. We have figured out, next slide, we have figured out that it The incubation period is around 5 days. The first 3 days are usually the latent period, followed by an infectious period. And the symptoms can show up to 5 days after the start of the infectious period. And usually the disease process, if patients don't succumb to it, lasts a couple of weeks, although there's certainly been reports of patients being sick for long periods of time. Next slide. We have learned that it disproportionately affects our older population. In fact, if you look at this slide, the number of children who have died in the United States, at least as of a month ago, was about 12 children less than 5 years of age from this virus. Next slide. We have also learned that it disproportionately affects patients with other comorbid conditions such as cardiovascular disease, diabetes, respiratory conditions, and hypertension and cancer. Next slide. So initially, we learned that the primary reason for admission, at least the reason that we learned from the experience from Wuhan, was that most of these patients present with respiratory insufficiency, so they may develop hypoxia or dyspnea, which that sometimes seem to be out of proportion to their work of breathing. But many of these patients develop pneumonia, which would progress to ARDS with multi-organ dysfunction. However, in addition to the primary respiratory concerns that were first thought were the major manifestations of this disease process, at least for the first 2 or 3 months, that's all we were focused on was oxygen delivery, ventilators, and such. We then started learning that there are non-pulmonary manifestations of disease process as well. So there are GI manifestations, as Shaun pointed out. There's certainly CNS manifestations such as Guillain-Barré syndrome, and strokes, especially in the younger population, can also present with disease processes like DKA. So there's certainly a wider variety than just respiratory reasons for admission. Next slide. In fact, keep going. In fact, the CDC shows that there are the presentations can be a myriad of presentations. So again, you can certainly be asymptomatic or mildly symptomatic, which is actually the majority of patients. But the most common manifestations that gets you to seek medical care is fever, cough, and shortness of breath, and associated abnormalities. The chills or myalgias, headaches, and especially anosmia has also been thought of as a symptom that deserves further investigation for COVID-19. Next slide. But as we were starting to grapple with the respiratory and other major manifestations of this disease process, we started learning that young and middle-aged people, initially, we were mostly focused on our oldest population, and then realized that younger patients were also getting sick, some of them developing strokes in their 20s, 30s, and 40s. And then as Shaun mentioned, a new entity came around sometimes around April, talking about COVID toes. And then before you know it, next slide, we started learning these reports about the involvement of COVID-related disease in children, which initially got a multitude of different names, atypical Kawasaki's, PIMS, but then WHO and CDC both settled on MISC, which is Multisystem Inflammatory Syndrome in children and adolescents, which is temporarily related to COVID-19. Both of them put out announcements almost about 6 weeks ago declaring the emergence of this syndrome. So how do we explain this myriad of, next slide, the myriad of presentations as well as the appearance of this MISC in children? The first clue, next slide, please. Next slide. The first clue came from studies also from China, which showed that a lot of these adults that were being admitted had evidence for lymphopenia. And the more severe the disease process is, the more severe the lymphopenia was. In addition, the other lab abnormalities that were significant were elevation of inflammatory biomarkers such as C-reactive protein and procalcitonin, and then markers of hemolysis and fibrinolytic activity, such as elevated lactate dehydrogenase levels and elevated D-dimer levels. And all of these levels progressively increase as the disease process worsened. Next slide. So just about a week ago, Dr. Levine's group from Imperial College of London put out a paper on MISC lab abnormalities, and what they were also able to show, next slide please, was very similar lab abnormalities. So they also showed lymphopenia, elevated LDH, elevated D-dimers, elevated C-reactive proteins, and procalcitonin. So next slide please. So it appears that the MISC, multisystem inflammatory syndrome in children, is in fact the pediatric manifestation of the COVID-related hyperinflammation and coagulopathy, which is commonly seen in adults. And this, then, next slide please, serves as the definition for MISC, in which children less than 21 or 19, depending on which definition you're looking at, with evidence of clinically severe illness and no alternative plausible diagnosis, suspicion of COVID, with evidence of systemic inflammation, including fever and abnormal laboratory values such as C-reactive protein, ESR, fibrinogen, D-dimer, etc., were classified as MISC. Next slide, please. So what we see in a hyperinflammatory syndrome associated with COVID-19 is evidence of lymphopenia. In adults, the lymphocyte count, absolute lymphocyte count, is less than 20%. In children, it can be less than the 5th percentile for age. And we also have markers of elevated inflammation, such as CRP, procalcitonin, and ferritin levels, as well as the robust expression of multiple cytokines and chemokines, some of which I have listed here. Next slide, please. So if you go back to what we know about this virus, we know that it works through the angiotensin receptor type 2. And if you look at this flow diagram, what you can see is that angiotensin type 2 receptor itself, an ACE2 enzyme, causes the activation of mast receptors, which leads to vasodilatation and decrease in inflammation and fibrosis. What happens in this infection is when the virus binds to these ATT2 receptors, it downregulates these viruses, which shifts the predominance of action of angiotensin 2 to the angiotensin type 1 receptors. And those receptors are actually pro-inflammatory. They cause vasoconstriction, fibrosis, increase in inflammation, and increase in thrombosis. And that is a well-described phenomenon. Next slide. Thank you. So what we also know is that there is angiotensin 1 receptors activity itself causes the recruitment of monocytes and macrophages, as well as dendritic cells, which are on the front lines of the innate immune system. And these cells are hyperactivated. The hyperactivation of these cells leads to a clinical syndrome, which is marked by fever, high ferritin levels, pancytopenia, fibrinolytic coagulopathy, such as we've seen in COVID-19 in both adults and children, as well as liver dysfunction. Next slide, please. Thank you. Next. So this hyperferritinemia is known by multiple different names, including MAS or secondary hemophagocytic lymphohistiocytosis. The other marker of this disease process, which is lymphopenia, is also very interesting because there's a strong correlation between the degree of lymphopenia and the disease severity. All lymphocyte populations, including B cells and NK cells, are low, but especially T cell counts appear to be much lower. And this lymphopenia is probably a reflection of lymphocyte depletion as well as apoptosis recruitment out of circulation. What we know from sepsis literature is that there are a variety of different immune responses that a host can have to pathogen. The classic response that we usually associate with inflammation is the hyperimmune response. But in many adults as well as children, what we get is actually a hypoimmune response, in which you have depletion of the lymphocytes, which leads to secondary to elevation of IL-10 levels and other cytokines. Next slide, please. So we sort of covered, the fact that there is a robust inflammatory response secondary to COVID-19. What we also started to see is that there's also concern about increased thrombosis in these patients, as manifested by COVID toes, as well as
Hello, Dr. Bhutta. Dr. Pablo, hello.
Yep. Hello, everybody.
I think it looks like Dr. Adnan had just dropped off, so I'm going to stop sharing my screen, and hopefully I'll try to connect him back. But maybe in the meantime, we can have Dr. Pablo, you can share your screen and start your presentation. Thank you.
Okay, I'm happy to continue. So thank you for inviting me for this nice webinar on SARS-CoV-2 and the emergence of multisystem inflammatory syndrome in children. I think you can see my slide. So going on what both Shaun presented on the acute infection and Dr. Adnan on the inflammatory syndrome and the pathophysiology, I'm going to focus on treatment options for multisystem inflammatory syndrome in children. So I'm from Spain. I am a pediatric infectious disease specialist, and the epidemic in Spain, as you all know, reached after Asia. Italy and Spain suffered a strong pandemic in late March and early April. So this is important because we saw many cases in Spain in that ages. And nowadays we have confirmed around 245,000 PCR confirmed cases in Spain, all over Spain, children and adults. But we have performed a national serology study showing that the percentage of positive IgG by rapid test for SARS-CoV-2 is around 5% of the Spanish population, meaning that at least over 2 million of Spaniards were coronavirus infected. And this is important because it means that there is a huge part that goes undetected. And as I said, 245,000 cases confirmed by PCR, but we estimate that over 10 times that number is the people infected. And this is important because of this studying on the multisystem inflammatory syndrome is very related on the number of cases of children infected by coronavirus. So this is quite infrequent, but of course, a significant proportion of children got infected, they will show the inflammatory syndrome. So in Spain, in my hospital, in late April, we had 3 cases of the multisystem inflammatory syndrome. And we discussed this with other pediatricians all over Spain, but not only in Spain, Italy, the UK, France, and we were seeing the same pictures. So a severe multisystem inflammatory syndrome that were taking several kids to the PICU at that time. And we kept on seeing this in May, but it has clearly decreased. So we really think that it followed the main pandemic in about 3 or 4 weeks time after that. So it seems that it's a late onset inflammatory response to the coronavirus. So this we showed a couple of weeks ago. This is from the Spanish cohort of coronavirus infected children that is led by Dr. Tagarro and Dr. Moraleda in my hospital. And they were getting information from all the cases of coronavirus. And as you can see in green, the inflammatory syndrome started to appear in March, but it peaked in late April, early May, showing an interesting pattern of 3 or 4 weeks delay of this inflammatory syndrome. And very interesting, most of you probably know that the New England Journal of Medicine just published yesterday 2 cohorts in the US showing the similar pattern. So you had a little delay in the cases in the US, maybe the peak was in April. We know there's still several cases, and the cases of MISC have appeared later on. So in late April or early May. So very interesting because it seems to be an inflammatory condition after coronavirus. And several organizations prepare a diagnosis or a criteria to diagnose these children. And CDC had a diagnosis, ACDC and the UK, and I participated in the WHO work group making the definition for WHO. And we discussed, and of course this could be further discussed because this was a preliminary case this definition, saying that this is a children disease for children below 19 years with fever, persistent fever for 3 days or more, and 2 or more of the following, either rash or conjunctivitis plus hypertension or shock, myocardial dysfunction, or acute gastrointestinal problems, plus elevated markers of inflammation, such ESR, CRP, or procalcitonin, no other obvious microbial cause of inflammation, like bacterial sepsis that could mimic this, and evidence of COVID, either by PCR or most of the cases by serology. So as a short definition or description, is a pediatric hyperinflammatory multisystem with fever, rash, conjunctivitis, and a clear abdominal inflammation, with acute phase reactants, with not much lung, but a clear cardiac involvement. The echocardiograph shows easily systolic and diastolic dysfunction, with an EKG that is inspecific, but clearly have a significant proportion of the children have high troponins, and very interestingly, a very high NT-proBNP. It is clearly associated, we know now, with SARS-CoV-2. It's not only that the pattern is related to the infection, clear temporal association, but the positive serology by ELISA is in a significant proportion, and PCR not so common. And going into treatment, and I'm going to focus on that for the rest of my talk, is that the initial treatment that was suggested by a group, by the UK and most of the French teams, is to target inflammation, to focus on immunoglobulins plus or minus steroids. Of course, these several children, and these are a description of our 3 first cases, they all needed PICU admission because of the cardiac involvement. So first of all, they need a cardiac support. They need inotropic support. So as you can see, the 3 first cases received dopamine, and some of them even need norepinephrine. So support by the cardiac involvement and minor respiratory support, either oxygen therapy by nasal cannula, although some cases need at the end to be intubated and inserted in a mechanical ventilation. Okay, but if we focus on the proper treatment for these, as I said, the first line therapy, most of the groups are starting with IV immunoglobulins at 2 grams per kilo in 1 dose. And why is that? I have to remind that there has been no clinical trial, so we are treating these children by what we've learned before on what it looks like this syndrome like, but of course there is no evidence. And we approach this, I think, because we think this is a similar disease as a Kawasaki disease, but not specifically Kawasaki, or it is also similar to toxic shock syndrome, and they are both treated by IVIG. We know pediatricians very well how to treat these patients with IVIG, so it's a common treatment in pediatrics. It has low side effects, we know very well. And we have seen good clinical response in our children, but not only in our children. It is commonly used in UK and France, and there is several publications, both by the UK groups and the French groups, showing the benefit of this treatment. But of course, we have to be aware that there is no clinical trials. The price is high, and it is not available everywhere. So we have to take this into consideration when we come to low or medium income countries and how to approach. So an alternative is steroids that are more commonly available, and some children have been treated with this. In our protocol, we also only added to IVIG if the infection or the inflammation is severe or persistent, because it's a potent anti-inflammatory. We know that MISC is an inflammatory condition, and is similar that we use steroids in Kawasaki disease. And of course, these children, because of the severe presentation, we think that due to severity, difficulty ruling out bacterial infection, plus the abdominal symptoms, we think that a broad spectrum antibiotic is needed at least for the first days. For anticoagulation, we think that, as Adnan was presenting, is a very procoagulant inflammation disease. So we have to consider it in older children, especially over 12 years old, or with high D-dimers. And we have been, and we have written our protocol using enoxaparin. Okay. And for the antiplatelet, there is a big discussion. We consider low-dose aspirin in children that have Kawasaki-like disease or have a very high platelet count. Okay. So what about other treatments that have been used very commonly in adults, like antivirals or the immunomodulatory treatment? So in patients with severe presentation or without response in 24 to 48 hours, we consider adding antivirals, and the only antiviral that has shown benefit is remdesivir, and we only use it if children are PCR positive, and you all know that there is initial evidence that the remdesivir for the PCR positive adults, they might benefit from a shorter disease, and it has been recently approved both by FDA and EMA. But again, this is only for the children that have PCR positive and with a significant lung disease. For the other immunomodulatory treatment, apart from steroids or IVIG, you know that we have tocilizumab and anakinra, infliximab, most commonly used in Kawasaki disease. Tocilizumab, most of you know, that is an anti-IL-6 receptor drug. It has been clearly used in adults with high IL-6 because it has been shown that there is a higher mortality in adults with higher IL-6, and a good response in adults has been shown in different studies all over the world, although it's only preliminary because no clinical trials has so far shown benefit of tocilizumab. And there is a brief description in children, the use of tocilizumab in the MISC. For anakinra, as you well know, is an anti-IL-1 receptor drug, and it has been shown good response in adults. And very interestingly, 3 days ago, the American College of Rheumatology issued a clinical guidance for pediatric patients with multisystem inflammatory disease in children, and they were recommending anakinra over tocilizumab, but this is always based on the side effect profile and the previous experience with anakinra in other pediatric inflammatory or rheumatology disorders. So this is my presentation. This is what we know for the treatment and the different options. But as a summary, I think that the main treatment has to be with immunomodulators, mainly IVIG plus steroids. I want to acknowledge all my team in the hospital and the other hospital that refer patients to our clinic. Thank you very much.
Thank you, Pablo. That was great. I'm sorry my presentation got cut off as I was in the middle of it. I don't know what happened. But we'll probably hold all the questions till the end. I'm sure there's lots of questions coming in the chat room and in the Q&A button. But Jessica, if you could resume my presentation. I think there were just a couple of slides left that I just want to go over.
Absolutely.
Thank you.
I believe it was.
Yeah, just go to the next one.
Okay.
Yeah. So what we now know in adults is that they're certainly at a very high risk for developing thrombotic complications. About 35 to 40% of all adult patients who were initially admitted to various ICUs in China and Europe. Next slide, please. Developed thrombotic complications. These thrombotic complications included pulmonary embolism, as well as strokes and other major venothrombotic complications. So this is about 5 to 6 times higher rate of thrombotic complications than is usually seen in ICU patients. So that just gives you a little bit of perspective on how common these complications are. Next slide. So there were a series of studies that came out from Italy early on in this experience, which used a technique called thromboelastography, and which was able to show that the blood is very hypercoagulable in these patients. Next slide. And the reason for that is because there is a huge crosstalk between inflammation and coagulation. We usually don't attribute, we usually look at these two pathways separately. We don't consider them necessarily related, but they are in a big way. And one of the sort of major mediators of this is a compound called tissue factor, which is upregulated in its expression anytime there is any injury, such as infection or hyperoxia or any other damage that occurs to the cells, causes an upward expression of tissue factor, which then leads to a very prothrombotic milieu within the local environment, as well as if it's a robust systemic response, then you can develop the systemic prothrombotic environment because of this presence of tissue factor. Next slide. So we've had some experience dealing with this type of crosstalk between inflammation and coagulation in the past, where we see this happen a lot in patients who have ventricular assist devices present, any inflammatory stimulus such as a viral infection, bacterial infection, surgery, trauma can cause an upward trend in their inflammatory markers. And what we noticed was that as soon as the inflammatory markers started going up, they started becoming more prothrombotic on their thrombolastograms, which we do on a daily basis on these children. And what we then also noticed was that if we treated them with steroids at low doses, so sort of in the 2 to 4 milligrams per kilo per day of methylprednisolone for a 3 to 5 day course, that we were very quickly able to bring down both the acute phase reactants as well as the prothrombotic milieu of these patients. And that actually led to an incremental reduction in the incidence of stroke in these children. And that has informed our experience, at least here at Maryland, of using steroids as the first line. I know Pablo talked about IVIG as the first line. We've used steroid almost in that dosing almost exclusively with very good results so far, albeit our experience is small. But we've really not had any progression once we start steroids in these patients. So I'll just leave it there, because it will probably lead this discussion about steroids versus IVIG probably has some impact on our next speaker as well. Our next speaker is Jhuma Sankar. Jhuma is an associate professor of the division of Pediatric Pulmonary and Critical Care at the All India Institute of Medical Sciences in New Delhi, in India. She has done extensive work in the field of sepsis and septic shock in critically ill children, and is very well published in this area. And she will be talking to us about the MISC from a perspective of its presence in South Asia, and how they are dealing with MISC in India and Pakistan as well as Bangladesh. So Jhuma.
Thank you, Adnan, and a very good evening to everyone. Greetings from India and from South Asia. And first of all, I would like to thank Dr. Adnan and his team for giving me this opportunity to present the experience from the South Asian countries. I work at the All India Institute of Medical Sciences. This is the COVID-19 dashboard of the WHO. And as you can see, the number of cases so far from Southeast Asia has crossed over 600,000. This is the COVID-19 dashboard of the South Asian countries. And when we talk of South Asia, we talk of India, Pakistan, and Bangladesh. The number of cases that have been reported have crossed more than 600,000 in this part of the world. And the deaths reported are more than 20,000. While reports of Kawasaki-like illness, hyperinflammatory syndrome, surfaced as early as April from the Western world, we started seeing these cases only from the beginning, from the first week of May. One such case has been published by our colleagues from Chennai in the Indian Pediatrics. And following that, we have been seeing these cases from various parts of the country. At AIIMS, our first encounter with a suspected case of multisystem inflammatory syndrome was in the middle of June. This was in the next slides. I'd just like to walk you through how we approached this case and how we managed this case. So this was a previously healthy 6-year boy who presented to the ED with 4 days history of fever, malaise, poor appetite. He had a maculopapular rash, and the residents in the emergency also noted that he had redness of the eyes and he was short of breath. So in the emergency, the child was clearly in respiratory distress, and he also had shock, and he had the classical features of Kawasaki-like illness. So we started the child on high flow oxygen. He was given a fluid bolus and also started on inotropes. on epinephrine. However, there was no improvement in the shock, and we had to add noradrenaline and milrinone to the drugs. And the child was also intubated and mechanically ventilated and subsequently shifted to the PICU. So the differentials we considered at this point in view of the clinical presentation was probably a Kawasaki-like illness, toxic shock syndrome, and sepsis and multi-organ dysfunction, which is common in these parts of the world. The index case fulfilled the classical clinical criteria of Kawasaki disease. So was it isolated KD or was it COVID-19 related KD? We needed to explore further. The other differential we closely considered was sepsis, septic shock, and toxic shock syndrome. And the child had clinical features of both of these conditions. So in view of, we cannot rule out sepsis or toxic shock syndrome in these kind of children. So we started on broad spectrum antibiotics, ceftriaxone and vancomycin, and also on supportive care. So this child clearly had a diagnosis of Kawasaki disease with shock. And if we see the recommendations for treatment for Kawasaki disease, 5% present with KD with shock, and this is a condition which is readily responsive to IVIG. So in view of this, we started this child on IVIG at 2 grams per kg, which was administered over 24 hours. We investigated the child, and he had all kinds of abnormalities, lab abnormalities. All the markers of inflammation were elevated. He had anemia, neutrophilic leukocytosis, there was hypoalbuminemia, deranged liver enzymes, but the COVID-19 antigen testing was negative at this point of time. We also did an echocardiography to look for LV dysfunction, and this child had LV dysfunction, even though the troponin I level was just borderline. We wanted to rule out other infections which are common to this part of the world, and all the investigations were negative. As we had a high index of suspicion of SARS-CoV-2 related Kawasaki-like illness, we also sent a serology for SARS-CoV-2, and that turned out to be positive. The criteria laid down by WHO and the CDC, the preliminary criteria has already been discussed, and this child clearly fulfilled the case definition of MISC criteria laid down by both of these organizations. So our diagnosis was Kawasaki disease, probably temporarily related to SARS-CoV-2 infection. And this is the course of the child. The child had shock, respiratory distress, cardiac dysfunction. He also had some GI dysfunction, and we found gallbladder edema and ascites on ultrasound, which has also been described in these cases. All of these issues fortunately resolved by day 5, and the hyperinflation also improved, and the child was discharged after 10 days of hospitalization, and the repeat echo which we did in the 2nd week was normal. We plan to follow up this child at 6 weeks to repeat an echo. So that was the case that we saw and managed at AIIMS. This is the other case I was talking about. This is the first case, in fact, reported by Dr. Bala from Chennai, and the presentation was almost similar to what we saw. The only difference was this particular child did not respond well to IVIG, and he also needed IL-6 inhibitor tocilizumab, to which he responded, and he was discharged. Following these, the first case, as I said, several cases have been reported, and this table shows you the data from 13 hospitals from our country. And as you can see, of the 191 COVID-19 children diagnosed, almost 17 had multisystem inflammatory syndrome. They fitted into the criteria, and 30 required ICU care, and 9 died. I inquired individually of the 9 deaths, and most of them had comorbidities. So when we classified these, the 17 cases into the spectrum of multisystem inflammatory syndrome, we could see that almost 40% had KD, almost 50% in fact had KD or incomplete KD with shock, and the other 50% had a multisystem inflammatory syndrome with or without myocarditis. As Dr. Pablo said, yes, we do treat these children with steroids and IVIG, and they were given steroids and IVIG. All the kids had received steroids and IVIG. 5 children also received tocilizumab. Now, when we are managing these children, there are some challenges which are unique to this part of the world. There are the clinical features overlap with other tropical infections. We do not have serology. We cannot estimate the serology for SARS-CoV-2, and we may not be able to diagnose this condition. Decision to administer IVIG is also individualized. Resource availability is also a concern. We may not be able to do echocardiography in all of these children. Laboratory testing availability and their utility is also questionable. PICU beds, ventilator beds availability is also an issue. And of course, IVIG, IL-6 inhibitors, they have cost and availability issues. So these are the challenges which we are most likely to face when we are going to manage these children. And now I'll be sharing the data from Aga Khan University. I thank Dr. Abbas. He has been very helpful, and he has provided this data of the 29 patients that they managed. And as you can see, the spectrum that of the children from Pakistan is almost similar. They have similar kind of presentation, GI symptoms are there, and they found almost 60% had LV dysfunction on echocardiography, and 7 children died. All the 7 children had one or the other comorbidities. If we classify the children from Pakistan, we could classify them as 25% or 1/4 had KD with shock, and the remaining 40% had features of TSS or myocarditis. In Pakistan, they were treated with almost 30% received IVIG. Again, there is issue of cost and availability, and almost 90% received steroids. The challenges faced by Pakistan are almost similar to what we face over here. In addition to both the challenges that we face in both these countries are awareness and recognition may be an issue, which may delay the diagnosis. The remaining challenges are almost similar and unique to this part of the world. Putting together all of our experience with these cases and the limited data that we have on treatment, this is a suggested approach. This is only a suggested approach to multisystem inflammatory syndrome in children. And I'd just like to run through this before I end my talk. So if a child in this part of the world healthy child, presents with fever and has shock, respiratory distress, or multisystem involvement, by which we mean more than 2 organs are involved, we have to rule out common causes like dengue, scrub, leptospira, malaria, enteric fever, other suspected bacterial infections, and also screen for COVID as per guidelines. Now, there can be 2 situations here. One, the child may have features of KD or incomplete KD, or the child may fulfill criteria for sepsis, septic shock, or TSS. So if the child is not having features of KD, and he is having features of sepsis, septic shock, we send appropriate investigation, start broad spectrum antibiotics and supportive care. But if there are features of KD or incomplete KD, we send markers for inflammation as well as for myocardial cell injury. If these are elevated, we have to manage the shock, respiratory distress, add antibiotics, because again in K, we cannot rule out infection in this group of children. We start these children on IVIG and aspirin at 30 to 50 mg per kg, which is again tapered. Once the inflammation subsides, the dose is 3 to 5 mg per kg till 6 weeks. And if there are no coronary artery involvement, the aspirin is stopped. Following this initial management, we assess for improvement. We send all the investigations again. If there is no clinical improvement or worsening, we consider repeating a dose of IVIG or give IL-6 inhibitors and continue steroids, especially if the child is coming from a hotspot area. If there is improvement, and after the second dose, if there is an improvement, we taper the steroids over 2 weeks, we continue aspirin and follow up echo at 6 weeks. Now, if you see the other limb, we again send appropriate investigations. We do an echocardiography to rule out myocardial dysfunction. If there are features of myocardial cell injury, we may consider IVIG and steroids on a case-to-case basis. And if there is no response, definitely we should consider testing for COVID antibody. And if the child is coming from a hotspot area, we may have to consider IVIG in this child, even if there is no myocardial cell injury, or give IL-6 inhibitors or give steroids. And if we have already given a dose of IVIG, we may have to repeat that. So this is in brief a suggested algorithm for the South Asian countries. And with this, I come to the end of this presentation, and the To summarize, the MISC, the Multisystem Inflammatory Syndrome, is a new spectrum of vasculitis and inflammation which we are witnessing due to SARS-CoV-2 infection. The spectrums in children that are seen are KD, incomplete KD with shock, multisystem inflammation with or without myocarditis. The presentation in the South Asian countries is almost similar to what is reported from the West. It is important to differentiate KD because the myocarditis due to KD responds well to IVIG. So we have to have a high index of suspicion and start treatment early. Most cases improved in both the countries when they were treated with steroids IVIG. And as I discussed, the challenges to South Asia are unique and require context-specific solutions. With this, I would like to sincerely thank my seniors from my institute and my seniors and colleagues from the rest of the country, and also Dr. Joved Chisti from Bangladesh. I would also like to thank our colleagues from Pakistan for giving us the data. And with this, I would hand over to Jessica.
Thank you very much, Jhuma. That was great. I know that we're running a little behind, but there are some questions in our Q&A box. So I wanted to make sure that we address as many as we can. The first question, Pablo, this is probably for you, is why, sorry, I think that got answered. So I'll maybe answer this one. There was a question about why is there a delay in children when cytokine storm is the cause in both adults and children. So I think the question is, why is there a delay in presentation in children whereas the adult disease process seems very rapid? I think the answer is has to do with the fact that children have seem to be more resilient, probably for 2 or 3 different reasons. One would be that the lymphocyte count in children is higher than adults, and as we know from the literature, as the person ages, their lymphocyte count progressively goes down. Lymphocyte counts also go down progressively with other disease processes such as cardiovascular disease, hypertension, diabetes. So this another reason why you would have low lymphocyte count. And I think that it's the absence or depletion of lymphocyte counts which makes the macrophage response even more pronounced. And so the likelihood of developing a cytokine storm as a response, as a secondary to macrophage activation or secondary HLH is probably higher when you have depleted lymphocyte activity. So I think that's the answer to that. I think that's why it takes longer, because children just have a higher lymphocyte count. Pablo, do you have any, or Shaun, do you have any thoughts on this?
No, I agree with what you said.
Okay. The second question is on Jhuma. Maybe you may want to take this. We see a hyperinflammatory secondary HLH type pattern very commonly in dengue in India. They would all fit in the definition of MISC. We have used IVIG in those patients as well. MISC is probably an uncontrolled immune response seen with so many other diseases. Comments?
Yeah, so Dr. Namit is my senior colleague there, and he one of the cases was well managed by their unit. And yes, I agree that as we already discussed, that we need to rule out infections like dengue in these children, because the clinical symptomatology overlap with so many of these infections. And this kind of hyperinflammatory syndrome is very commonly seen with dengue in our in this part of the country. So I don't think there will be a difference in the treatment, because management would be IVIG and steroids if we suspect HLH. So management wise, it would not change, but definitely we may not be able to differentiate between the two conditions. The only thing that can help us is probably if we have a SARS-CoV-2 serology or antigen positive, we can attribute it temporarily to the SARS-CoV-2 infection. I would, other panelists to comment?
You have more experience. I don't see dengue. We have discussed several cases with Latin America, but they didn't have, so they had dengue and they have rash, but they didn't have that hyperinflammatory syndrome.
Yeah, yeah. So I would say it will be hard when you have other diseases that can induce secondary HLH or MAS to differentiate. So I think, you know, one of the sort of foundations for the MISC definitions as they currently exist from the WHO and the CDC, and I think the Royal College, is that you should have the absence of any other plausible explanation for the inflammatory response and a positive SARS-CoV-2 PCR or serology, or at least a positive history of exposure. Now, I think those definitions are well and good for right now, when this is a new infection which is just starting to spread through the general population. I think 6 months from now, we'll have to adjust those definitions because there'll be a lot of people who will have antibodies to SARS-CoV-2, and so we can't necessarily rely on serology, at least as a you know, explainer for the MISC. So I think, you know, this is a disease in evolution. Like I said, you know, it really has come into attention just in the last couple of months, and so I think we're learning every day more and more about this, and I think there'll be changes in definition as we go along. Okay, so the next question is about steroids. So I think I created that controversy. So Pablo, you had mentioned.
So I think the idea is to use low dose steroids. High dose steroids, I think, is too much for this presentation that we say is severe, but we have seen quite a good recovery after a few days, like we presented several of the cases. So I would say either steroid by low or medium dose would be recommendable, either methylprednisolone or even prednisolone if they can receive oral, or the dexamethasone, but we usually use methylprednisolone.
Yeah, Shaun, any comments on that?
I mean, it would be the same at our institution. We use methylpred, and IVIG is used really only if the features of Kawasaki disease proper are also present. But if the case doesn't meet the definition of Kawasaki disease, and it's just MIS-C with organ involvement, we would use steroids as first line.
Yeah, and I would say that's also our experience here at Maryland. We've used steroids as first line for about the 9 or 10 patients that we've had, and probably given IVIG to only 2 of them, and that was also probably a soft call. So most of them have been responding to MISC. I think part of the issue also is when they present in their disease process. So I think if we can diagnose them early on, when their only symptom may just be this vague GI complaints that most of these patients seem to have, then I think you can have better outcomes with just low dose steroids. I think if you let this disease process smolder for days or weeks, then they usually present much sicker, and I think then you sort of end up having to hit them harder with everything you have.
And one thing to add, I think, is an important question that we don't really know the answer yet to. And there have been a couple questions about this, is sort of the cardiac manifestation. So number one, I think involving your cardiology colleagues is important. The acutely sick kids, in my experience, seem to be coming in with left ventricular dysfunction, but some of them have gone on to develop coronary artery dilatation. And I think that is important in terms of the IVIG. I mean, I think we don't know yet how using or not using IVIG may increase or decrease.
So we've got just a few minutes left, and I wanted to firstly thank you all for a fantastic session. I recognize that there are probably about a dozen questions on the chat that are not yet answered, and I would encourage our panel to maybe provide us some feedback on those, and we can post it as part of this recording for those who have joined. There are as many questions that are emerging from the syndrome as there are potentially answers that we're learning, and all of you have illustrated that. But the thing that I wanted to underscore is really the importance of an emerging research agenda that will allow us, some 4 decades into the emergence of Kawasaki disease, to unravel the continuum of this disorder. This has been one of the greatest mysteries out there in public health. To those of us who knew Dr. Kawasaki personally, and he just died a few weeks ago. Adnan, your father, knew him very well, and I've had the pleasure of meeting him several times. He always underscored that while we knew much about Kawasaki, there was far, far more that we did not know. And this is now an opportunity in looking at the syndrome and the continuum for putting together perhaps a multi-country, multi-center research agenda around some of the pathogenesis. I know that WHO and colleagues, Pablo, you're part of that group. You are looking at this in detail, but there is an opportunity for the coalition of centers in global child health, for maybe initiating some work which will allow us to understand some of the fundamental mechanisms. I mean, WHO will, of course, do the research that is relevant to public health and epidemiology, but academic centers and centers in global health research will have an opportunity for understanding the fundamentals. So I think the fundamentals in here offer a tremendous opportunity, and I'd like to encourage the 4 of you on this panel to maybe spearhead an activity on behalf of the coalition to see if we can initiate and start some kind of a multi-center collaborative research agenda into the pathogenesis and understanding some of the fundamental biology behind the multisystem inflammatory syndrome. So I know we are almost at time. I wanted to take the privilege as the chair of the coalition to thank you all for your efforts and to inform those who are participating online, and we've had a very good turnout, over 160 people that we anticipated would be around that number, to stay in touch, because this is the first of our sequential series of webinars that we will have on the subject. The next one will be on adolescent health, and particularly the effect on school-age children. I want to point out the absolutely fantastic statement put out by the American Academy of Pediatrics today on getting children back into school. And then there will be one to follow on the very important issue of immunization, and also the immunization hesitancy that is plaguing us. So thank you very much for your time. I'll beg your leave, but I want to end with a note of profound gratitude to all of you for your donation of efforts and for your scholarship in making this a success. Thank you.
Thank you.
Thank you.
Bye.
Bye.
Bye-bye. Thank you.